topic for this video is glomerular filtration rate, glomerular capillaries and GFR. Here you can see a diagram of a nephron, which is the functional unit of kidney. 1 million per kidney, loss of nephron, other nephrons have to compensate. They have shown a glomerulus which has a group of blood vessels. Urinary excretion equals to filtration minus resorption plus secretion. In the Bowman's capsule, you have afferent arterioles which are more thicker and efferent arteriole which are slimmer, and only capillaries in between two arterioles is glomerular capillaries. Bowman's capsule. Number 1, filtration followed by reabsorption followed by secretion followed by excretion. Plasma filtrate is collected, and then you have the peritubular capillaries shown. Ultrafiltrate, filtered fluid, ultrafiltrate. Proteins are not filtered, only plasma is filtered. Normal GFR is 125 mL per minute or 180 liter per day. Reasons for protein not being filtered: heparin sulfate, line glomerular capillaries, negatively charged and repel proteins, anions, anything with negative charge. In renal disease, proteins are filtered due to loss of heparin sulfate. Here is the slit diaphragm, fenestrated endothelium. Fenestrated endothelium is the small gaps between cells up to 4 to 8 mm, restrict protein passage. Slit diaphragm, food process, reinforces the fenestrations, smaller gaps, slit diaphragm of podocytes, restrict protein passage. Integrity of slit diaphragm is maintained by nephrin, podocin, and alpha-actinin. Nephrin mutation leads to protein excretion. So nephrin protein mutation will cause protein excretion, and the syndrome is congenital Finnish type nephrotic syndrome, NPHS1 gene. Podocin, steroid resistant nephrotic syndrome. Alpha-actinin, focal segmental glomerulosclerosis, FSGS. Filtration process. Forces. Starling forces are hydrostatic pressure in the glomerular capillaries, represented by PC, which is 60 mmHg, oncotic pressure in glomerular capillaries by pi C, which is 32 mmHg, hydrostatic pressure in Bowman's capsule, PP, which is 18 mmHg. Factors and forces favoring filtration is the hydrostatic pressure in glomerular capillaries. Factors opposing filtration is the oncotic pressure in glomerular capillaries and hydrotic pressure in Bowman's capsule. Applied aspect: presence of renal calculi, oncotic pressure of oncotic pressure of hydrostatic pressure of Bowman's capsule is increased, and decrease in GFR. Net filtration pressure: forces that favor filtration minus forces that oppose filtration. Forces that favor filtration is hydrostatic pressure in the afferent arterioles, glomerular capillaries, minus the sum of hydrostatic pressure in Bowman's capsule and oncotic pressure and glomerular capillary. So 60 minus 32 point plus 18 is 10 mmHg. So the net filtration pressure is 10 mmHg. Measurement of GFR. Criteria of substance to be used to measure as GFR is that it should be freely filtered, there should be no reabsorption, there should be no secretion, and it should be non-toxic. Substances: inulin. Inulin clearance rate by normal kidneys is 125 mL per minute, which is normal GFR. Gold standard: inulin filtered is equal to inulin excreted. Procedure: inulin clearance. Intravenous inulin plasma filtered in kidneys, excreted in urine. Filtration: plasma into plasma concentration is equal to urine concentration into volume. So glomerular filtration rate into plasma concentration equals to urine concentration into volume. GFR equals to urine concentration into volume divided by plasma concentration. If plasma concentration increased, GFR is decreased. Creatinine. Plasma creatinine is used for estimation in clinical practice. Increased plasma creatinine, decreased GFR. So increased plasma concentration, decreased GFR. Plasma creatinine is used for estimation in clinical practice, which correlates that increased plasma creatinine equals to decreased GFR. Cystatin C, newer marker for GFR. Applied aspect, relation with GFR and substance. Clearance equals to filtration rate is inulin. Clearance is more than glomerular filtration rate. New set secretion is para-aminohippuric acid PAH. Clearance is less than glomerular filtration rate. New net resorption is glucose. Renal circulation, renal blood flow is 100 and 250 mL per minute, which is 20 to 25% of cardiac output. Renal plasma flow, 55% of renal blood flow equals to 625 mL per minute. Measurement substances used is para-aminohippuric acid. Formula: effectiveness estimated renal plasma flow equals to urine concentration of PAH into volume upon plasma concentration of PAH. So true renal plasma flow equals to effective renal plasma flow upon extraction ratio 625 upon 0.9 equals to 700 mL per minute. Extraction ratio is percentage of PAH excreted by kidneys, which is 90%. Filtration factor, GFR upon renal plasma flow equals to 125 upon 625 equals to 20%. 1/5 of the renal plasma is filtered at any point of time. Regulation of GFR and renal blood flow. Constriction of afferent and efferent arterioles. Substance: norepinephrine in shock sympathetic stimuli. Effect on arteriole and capillaries. Constriction of afferent arteriole, decreased blood flow to glomerular capillaries, decreased PC. Effect on GFR, decreased. Effect on RBP, RBF, renal blood flow, decreased. Angiotensin 2. Constriction of efferent arterioles. Biphasic response. Initial phase is stronger. Blood pooling in glomerular capillaries. Increased oncotic pressure of glomerular capillaries. Increased GFR. Later phase, increased protein in glomerular capillaries. Increased oncotic pressure of glomerular capillaries, decreased GFR. So effect on GFR, glomerular filtration rate, due to angiotensin is increased GFR and later decreased GFR. Effect on renal blood flow is decreased in both phases. PGE2, also known as renal prostaglandin, produced by renal medullary interstitial cells. So RMIC, renal medullary interstitial cells, produce PGE2, also known as renal prostaglandins. They cause dilatation of afferent arteriole, increase blood flow to renal cortex, and decreased blood flow to renal medulla. Glomerular filtration rate is increased and renal blood flow is increased. ACE inhibitors. Dilatation of efferent arteriole. Blood moves quickly from glomerular capillaries with ACE inhibitor due to dilatation of efferent arterioles, which is decreased hydrostatic pressure of glomerular capillaries. So GFR is decreased and renal blood flow is increased. Note, efferent arterial constrictions, that is increased oncotic pressure in peritubular capillaries. Autoregulation. Despite perfusion pressure change, there is no change in GFR and renal blood flow. Occurs between 80 to 180 mmHg. Doesn't need neural influences. Occurs in denervated kidney. Mechanism myogenic, that is vascular. Increase renal blood flow, vessel wall stretch, opens calcium channels, calcium influx, vasoconstriction, decrease renal blood flow. Tubuloglomerular feedback, negative feedback mechanism. Increased glomerular filtration rate, increased NaCl filtration, activates muscula densa, glomerular filtration rate sensor, release adenosine, constricts afferent arteriole, decreased GFR. Applied aspects. Proteins require sodium for their absorption. High protein diet, sodium reaches macula densa, increased GFR. Mesangial cell contraction and relaxation. Decreased GFR, endothelin, angiotensin II, norepinephrine, mesangial cell contraction, decreased blood flow to capillaries, decreased GFR. Increased GFR, nitric oxide, dopamine, calcium, cyclic AMP, natriuretic peptide, mesangial cell relaxation, expansion of capillaries, increased renal blood flow, and increased GFR. Mesangial cell, glomerular capillary. We will continue with proximal convoluted tubule.